Our next speaker is Kyra, also from the biology department. She is a graduate student. She'll be talking about her thesis, and I just found out that this particular presentation is on a paper that's already been published, right? So congratulations.
Good morning. I'm a little bit under the weather, so please excuse me. But here is my project. Thank you, Dr. NT. It's not been possible without my thesis mentor, Dr. Lisu. And the title of mine is Combination of HDAC and FYN inhibitors in synovial sarcoma treatment. So, what we will learn today is what is synovial sarcoma, what SS18 SSX is, and its relevance to synovial synovial sarcoma, what HDAC inhibitors are and how they are used, what is FYN and its significance, and then what is drug combination and its synergy. So, what is synovial sarcoma? It is a deadly child cancer disease. It mainly attacks the joints and the soft tissue in the body. It is mostly seen in the ankles and in the knees, but it can be seen elsewhere. It is highly aggressive, and when it metastasizes, it can spread throughout the body in soft tissues such as the lungs, the bones, lymph nodes, and eventually the brain. It is most often misdiagnosed, which is why the metastasis rate is about 15%. And when that happens, the individual has only about 24 months to live after diagnosis. So, continuing on, what we have been able to find is that SS18 SSX is a common gene or a cancer-causing gene that is directly linked to synovial sarcoma. In cancer, typically each patient is unspecial in that their particular cancer is selected to them. However, with synovial sarcoma, each of the patients have this particular gene which makes us able to know that this is this particular type of cancer. And what makes this gene so interesting is that it is a physical fusion. So you get the loss of both sides, but at the same time, when they're joined together, they combine to be a activator which turns on the genes so that it can continue on the cell proliferation of the cancer, but at the same time, it will repress all of these cells around it that will try to kill this cancer. So what is the biological significance of SS18 SSX? In this particular study, we were able to see that when SS18 SSX is overexpressed in mice, it was able to cause this devastating disease. And when it was deleted, we were able to see the cell death, which did end up of itself decrease the cancer. So in this particular graph, if you would look at image A, we are able to see that when SS18 SSX are fused together, they're in the dark portion are, and then continuing down in the small box. SS18 SSX, it regulates whatever so the pathways are under it, and when this happens, and we use an HDAC inhibitor to block it, in all of the greens, you can see that all of those are regulated or non-expressed. But we were able to also see that when SS18 SSS is blocked by an HDAC inhibitor, that the red fin is no longer regulated, and this is where the issue arises. And here in B, in compared to C, you're also to see just that reinstating. And you may ask yourself, why is this an issue? This is an issue because I know that a lot is going on in the picture, but FYN is a tyrosine kinase, and that typically means that it involves heavily in cellular pathways. And if you just in all of the boxes that are highlighted in red, you're able to see that it is involved in apoptosis or cell death, proliferation, so it can continue on, and then finally in migration to where it's able to spread. And when you add all of this together, we are able to see that FYN is what causes the therapeutic resistance to when we enact upon SS18, SSX. So, which brings us to the issue. If we know that SS18, SSX is able to inhibit FYN, then the disruption of SS18 should be a HDAC inhibitor, which for my project was FK228, will then cause the activation of FYN. If this theory is correct, then if we are able to use a HDAC inhibitor, for my project it was PP2 to enact on FYN, then the two drugs can synergistically work together to increase the effectiveness of this treatment. Okay, so my methods are, we have a MTT, a SAY, and A. This is simply to test the cell viability. We plate the cells and we then add drugs to them, we let them incubate, and then we add a purple dye that just evaluates how many cells were alive after we drug them. And we have the one assay to whereas the cells have to travel through a very thin filament to reach the media nutrient-rich fluid at the bottom. And when this occurs, we are able to map and see how many cells are able to make it through the membrane after they are drugged. And here at C, we have the Western blot, which checks and analyzes the protein and how, in the practical studies, how it is able to be transpired onto a filament paper, which we can read and screen and see the heights and levels of that. And then D, we have a 3D multicellular spheroid colony, which is we put colonies on top of a petri dish lid, let them hang, and then we take pictures and analyzing how they are growing in a particular environment. And then drug synergy analysis. This was essential for my paper because we were trying to test and see how the two HDACs were able to work together to be able to get the sweet spot to whereas the tumor can decrease as well as the cancer. And if you look at the particular images, the more red that it is, the higher the cell death. Then continuing on, here is an image from some of our research as to where we're able to see that in the control versus the experimental groups, just how effective this particular treatment is. And here's just one of the colonies, the three spheroids that I was talking about. And then in conclusion, the combination of the two HDAC inhibitors show great promise as to being a really effective way to combat this particular childhood cancer. But of course, more research needs to be conducted before it is used on human subjects. Thank you for Jack State for the biology department which I conducted this research. Thank you for my mentors and my lab mates who helped me along the way, and Frontiers for publishing my paper. Congratulations. Any questions?
Any questions?
When is misdiagnosed? What is it usually misdiagnosed as?
It can be arthritis, bursitis, just inflammation.
They think that in children? That's kind of odd.
It is, but you really only know after the x-ray, but most of the time it won't get that far until it's too late. Yes.
Have they did like prior testing such as handwritten or MRIs and like midget x-rays to make sure it's correct?
If I'm understanding your question correctly, when it comes to like synovial sarcoma, I believe we take like skin grafts of the tumor tissue, and then once we are able to identify SS18, SSX as the issue, and then x-rays will follow after that. But if that answers your question, does it?
It does.
Questions? If not, another round of applause for